Okay, hopefully you can all now see my screen and that you are in the place you were expecting to be at this time of day for Accessing Mental Health Services, a DeNPRU Exeter webinar. So, unsurprisingly, given the title of our webinar, we are DeNPRU Exeter. So we are one of two NIHR Policy Research Units focusing on dementia and neurodegeneration. And while Exeter is our kind of HQ, we are a consortium of different universities around the country and even with a collaborator in Sydney, Australia. Policy research units are composed of experts and researchers, and we undertake policy research to provide evidence to support national policy making in England. And that's primarily through the Department of Health and Social Care and its arm-length bodies. However, it's important to note that the views expressed during this webinar are those of the authors and not necessarily those of either NIHR or indeed the Department of Health and Social Care. So we work to benefit everyone living with a neurodegenerative condition and all of those supporting them. So that can obviously be family members, friends, but those crucial professionals and practitioners who we meet along the way. So just a kind of example of why this topic is one that's close to our hearts. A few of us, including DeNPRU Exeter Director Linda Clare, came previously from the IDEAL programme, which was a longitudinal cohort study around living with dementia in the community and kind of which things make a difference to experiencing a good quality of life with dementia. And what all of our research showed was that for both the person living with dementia and the carer, that the single biggest influencing factor was psychological characteristics and health. And for me, that's actually quite a positive, hopeful finding because there are things that we can do to ameliorate psychological health. There are mechanisms out there, whereas dementia symptoms might be a bit more intractable to current treatments. So what I'll do is I will share, once I'm no longer sharing my screen, I will share this resource with you in the chat in case that's something that you'd like to look at. These were made for practitioners and professionals and are freely available on the internet. So, who are we going to hear from today? Well, we've got 4 speakers, 2 from the professional world and 2 experts by experience, because it's really important for us to understand how this kind of manifests and makes a difference in people's real lives as they live and deal with these kinds of conditions. And I'm going to introduce them individually as we go along. Once each of them has spoken, we'll open for audience Q&A, and I really encourage you to get involved, whether that's through the chat or coming off mic. And just to point out that our final speaker, Rick, is the gentleman behind the beautiful artwork that you will have seen advertising this webinar, Emotional Challenges in Neurodegeneration. So I just wanted to give this beautiful artwork another moment on the screen. Okay. So I'm going to stop sharing this presentation and I'm going to introduce our first speaker, Emma Edwards, who I believe goes by the moniker of the Dolly Parton of Parkinson's. Well, that's what she told me. So Emma is a specialist Parkinson's nurse. She has a mental health background. She's also currently engaged in research, and she's a trustee of Spotlight Young Onset Parkinson's, which is a specific charity for young onset. So Emma, over to you.
Okay, can you see my screen?
We can indeed, it's perfect.
I do. Thank you for the invite. That's absolutely brilliant. I can't see you guys when I'm doing this, so if you are waving at me frantically, it might be worth putting something in the chat. So yes, my name's Emma Edwards. I've been a Parkinson's specialist nurse for the last 15 years, nearly coming up for 15 years. I'm a mental health nurse by background, which is a very unusual background to have as a Parkinson's specialist nurse. There's about 520 of us in the UK, and mainly have a general nurse background. So I think there's 2 of us that have a mental health nurse. And I've been a nurse overall for about 30 years. So I work for Live Well Southwest in Plymouth. I cover West Devon, or part of West Devon, Plymouth, and a bit of South Hams. Alongside a colleague, I have a caseload of 700 people with Parkinson's, all different stages of the condition. Wannabe researcher, really. I've just finished a fellowship, loved it, want to do my own research, so I'm really interested in that. And I'm also, if you haven't heard of Spotlight YOPD, it's a charity that supports younger people with Parkinson's, so under the age of 50. Most of the artwork that you'll see today is actually, I must credit him first of all, is Johnny Aitchison. He's a wonderful artist, but he's also an A&E consultant in Leicestershire, and he has Parkinson's himself and a YOPDer. So just so that you can kind of get a quick a refresher about Parkinson's. So it's a progressive neurological condition, and it's one of the fastest growing in the world. In terms of numbers in this country, we think we've got about 153,000 people in the UK. It is more common over the age of 65. Most people who get it get diagnosed in the 70s, but it can occur at any age. Children can get Parkinson's. It's incredibly rare. If you get it under the age of 50 or diagnosed under the age of 50, this is where we term that YOPD, young onset Parkinson's. Your risk, so Parkinson's UK put the risk of being diagnosed with Parkinson's at about 2-3%, or that's 1 in 37 people will develop Parkinson's. There's no cure, unfortunately, although there are so much research out there being done. Cure Parkinson's kind of lead the way with that alongside Parkinson's UK in this country. But there are so many symptoms in Parkinson's, some that you can see and then some that you can't. And the latter one is the one that I'll be talking about today. But we do think actually that there's this prodromal phase with Parkinson's. So this is where the neurodegeneration starts to happen in the brain, maybe 10, 20 years, 30 maybe, before you get the amount of symptoms needed for a diagnosis. And there's actually some emerging research to say that perhaps if you have an underlying mental health problem, are you a bit more vulnerable to developing Parkinson's, which interests me. Just a quick slide is all about the dopamine in Parkinson's. This slide here just demonstrates what kind of happens between those neurons. So dopamine, we think, is one of the main neurotransmitters that get affected by Parkinson's. When you don't have a great deal of that in your system, it can lead to these motor problems of tremors, slowness of movement and rigidity. But we also know that dopamine plays a big part in well-being. So not having a great deal in the tank for whatever reason, and we think perhaps it's a combination of environmental and genetic factors, can lead to these other symptoms as well. So we classify Parkinson's. To get the diagnosis of Parkinson's, you need to have stiffness, slowness of movement, one-sided tremor, and this be a one-sided presentation. It doesn't need to be diagnosed with the non-motor symptoms, but often what I find are these non-motor symptoms are more difficult and more of a challenge to deal with. So we think there's probably more than 30. I think the last time I looked, I think we had identified about 40 non-motor symptoms, and Johnny's done a brilliant little diagram there of some of the ones that you can that people may experience. It doesn't necessarily mean you're going to have them all, but things like apathy, urinary problems, postural hypotension, for example, but most certainly mental health problems. So again, when you look at the research, look at the literature, you can find different numbers, but broadly speaking, depression, low mood can affect nearly half of people that get diagnosed with Parkinson's. Anxiety, I actually think that's probably a lot higher in my personal experience, but about 20 to 40%. Mild cognitive impairment and dementia is a bit higher again, looking at maybe a quarter to half the people with Parkinson's will go on to develop that. We see a great deal of hallucinations. Sometimes that's a result of the Parkinson's medications. Sometimes it's a sign of early cognitive problems, or indeed if somebody has an underlying infection like a urine infection, that can make them experience all weird sort of mental health side effects. In terms of hallucinations, they tend to be visual in nature, very rarely sort of tactile or auditory, but occasionally that does happen. What we also see, and again, numbers are, depends where you look, 14%, 20%. I think in my own experience of being a Parkinson's nurse, probably a little bit lower, but in impulse control disorders. So what this means is, and this is often the result of certain Parkinson's medications as well. So gambling, hypersexuality, things that we're lighting up the brain with the Parkinson's medications. Those dopamine receptors are in our sort of reward centers of our brains. So when we light that up artificially with medications, if the doses are a bit too high or you're particularly sensitive, we can sometimes see these things as well. And something that is close to my heart as in terms of research is suicide awareness and prevention in Parkinson's. And what we do know is that unfortunately people with Parkinson's aren't immune to this. And it's around, on average, about 4 to 5 people. I suspect this number is a lot higher, but die by suicide every year. So accessing treatments for mental health when you have Parkinson's, it can be a challenge. I think sometimes it starts at the assessment. I think many colleagues that work with people with Parkinson's are not particularly trained to assess mental health issues. For example, as I said, I'm a mental health nurse. I feel very comfortable in this space, but my colleagues, my Parkinson's nurse colleagues, who are general nurses, perhaps haven't had the training to do this. But more importantly, if you ask, you need to know what to do with the answer, and that's not always clear. We're not entirely sure what what treatments for mental ill health are helpful. There's been studies over the years, you know, CBT therapy, mindfulness, acceptance and commitment therapy, that could be helpful. But I don't think we're absolutely certain to say this is the treatment that you need because you are presenting like this. I think a lot more work needs to be done. Another thing is that some medicines that we use for mental health can make Parkinson's symptoms worse. So, for example, if you are on a certain medication called rizagiline, theoretically, if you are on another antidepressant, this could induce something called serotonin syndrome, which can be fatal. So we have to be very mindful of other medications that people with Parkinson's have. Some medicines are not available in certain areas. So, for example, clozapine, which is a treatment for psychosis, there's really long waiting lists. So in Plymouth itself, you know, for a memory assessment, you're waiting 12 to 18 months. And what we also know is that often people with Parkinson's and memory problems have hallucinations. So it's really, it can be really quite challenging. We don't always work together with mental health services and psychology very well. And I think there is a lack of understanding about our different roles and our illnesses. And there is a lack of clinical pathways for that we've agreed at a national level when somebody presents with a mental ill health. So I think we probably know the consequences of not treating mental ill health, but I'm just putting it out there again. It causes a great deal of stress for the patient and their family and the clinician not knowing what to do particularly. And we know that untreated mental illness has lasting effects. It really does impact on physical health, on finances, emotional health. Can make Parkinson's symptoms a lot worse. You ask anyone with Parkinson's if they feel anxious and they've got a tremor, we know there is a link with that tremor being increased. We know it can make blood pressure worse. We know that people with underlying mental ill health have higher risk of admission to hospitals. We know, again, from my experience, that often Parkinson's nurses are the first point of contact for people with Parkinson. So they'll ring us, and that puts a great deal of strain on the services. And we have had retention issues with keeping Parkinson's nurses with such a busy caseload. We know that it increases hospital admissions, general and psychiatric hospitals. We know that there is an impact on the family. This carer burden can happen. And there's also pressure on other services, such as community crisis response teams. Ambulances may be called out because somebody is feeling so anxious. We know as well that, the on-off symptoms of Parkinson's and feeling off, you can get incredibly anxious and feel like you want to die. And it can also sort of have that impact on care home admissions, and that being a bit more likely. And then, of course, suicide and death, if these issues aren't addressed. Can we change things? Yeah, I think we can. I'm always pretty positive. So some possible solutions: definitely better integrated services, mental health services working more closely, more integrated with Parkinson's services. We need better training all around. We need to be doing prevention work with patients. We need to be looking at not only what do we do when someone experiences mental ill health, but how can we best promote mental health? We need to be sharing our good practice. And I will just quickly, my next slide is about that. We need to be looking after our staff a little bit better as well, so that they are in a good mind space to be dealing with quite challenging issues. We need these smoother clinical pathways, and we need to be designing these interventions that we deliver using the best evidence, using research that has been put together, with people with Parkinson's on these research panels. And we need to use, our voluntary and our social and our charity sort of organisation colleagues as well. So just to finish, really, and I know I've just gone over a little bit, some examples of good resources out there so that our colleagues and people with Parkinson's can have better mental health or a better understanding of mental health. Parkinson's UK do wonderful work. So again, if any clinicians are on this call and they would like to learn more about Parkinson's and mental health, there is an absolutely brilliant course that you can go on, and there's loads of information. I must do a shout out to the Neurology Academy, who run the Parkinson's Foundation and Masterclass, and certainly I teach on that about how to assess for mental health issues. Spotlight YOPD, I'd be sacked if I didn't mention them. They provide a space, online support, and building that community for people that are living with this condition. And I think if you can find your tribe, that is so protective for your mental health. Again, there's different resources that you can access. Ramona Wheel down in London did a brilliant work with people with Parkinson's and their family, looking at how can we better manage things like dementia, and put this toolkit together. And very recently, and you can find some of the, I think most of the talks that we did at Parkon in Leeds last month, we looked at the hidden symptoms of Parkinson's. And it was such a brilliant session when we had a lady come along and speak about her experience with her husband who had Lewy body dementia. Neil Archbold up in South Tees runs a clinic with mental health nurses, really collaborative working, really collaborative prescribing, and has really good health outcomes for his patients that are perhaps struggling a little bit. There is another excellent example up in Scotland, run sort of initiative led by Parkinson's UK Scotland, Anita Jeffries, supported by James Joplin, looking at different psychology inputs, guidance on complementary therapies. They're working towards sort of group work so mental health can be improved. Got fantastic feedback. But it's about also considering, could we have mental health nurses? Could we have psychologists in our team? Or could we just poach them? Would they lend a psychologist to us for a couple of hours? So again, I think we need to think about how can we work best with the resources that we've got. And that's me. So I think we've got a long way to go until there is that parity of esteem, until that mental health care is really valued as much as physical health care. But you know what? I think we can get there. Thank you.
Fabulous. Thank you so much, Emma. I mean, already people are absolutely intrigued in the chat, and I can tell we're going to have an interesting question time. But that was absolutely marvellous. And thank you for giving us also some of the solutions possible and the bit of the hope, because it's always important to keep that in view. Fabulous. So our next speaker is David Stephenson, who is Head of Policy and Public Affairs at the Huntington's Disease Association. So we're moving to quite a different condition now, different experience, but very, very important in terms of access to mental health services. So David, over to you.
Hi everyone. I don't have any slides, unfortunately, so you're going to be looking at me for 10 minutes, but hopefully that's not too bad. So my name's David Stephenson. I am, as Kathy said, I'm Head of Policy and Public Affairs at the Huntington's Disease Association. What this means in practice is that I lead our policy and influencing work, which could be at a local, regional level, working to influence integrated care boards and the NHS, and at a national level, working to influence the government, working with people affected by Huntington's disease to campaign and push for policy change. In terms of what Huntington's disease is, it's a neurodegenerative disorder. It's normally first onset of symptoms is between the ages of 30 and 50, although there is juvenile onset Huntington's disease as well. There's a 1 in 2 chance that if you have children, that each one of them will inherit the condition. So you could have 3 children, they could all end up with the Huntington's gene, or they could all not have it. It's a bit of a lottery in that sense. It affects movement in a big way. So you start, some of the first signs could be jerky, uncontrollable movements. It also affects thinking. So your ability to plan, organize tasks, so it affects you cognitively. And then behavior, and this links into mental health quite a lot. People can experience personality changes to their behavior. They might become more impulsive. I think it's touched on this earlier, actually, for Parkinson's. People have impulsivity, irritability, be more likely to be engage in reckless behavior. And then also speech and swallowing is affected in a big way. So it can be harder to communicate, and you end up, particularly in the later stages of the disease, finding it harder to swallow and have risk of choking. And on average, the lifespan after you've been diagnosed between 15 and 20 years. In terms of how Huntington's disease and mental health interacts, this is, I think, it's in 2 ways. I think one is that it's the mental health impact of having having a diagnosis like Huntington's, and particularly the genetic component of it, because you can be caring, and I've been in this role for 5 months. Mental health is the one thing that comes up more than anything else, and I think I'm myself going into this role, I didn't grasp how much mental health was such a big component of Huntington's disease and poor mental health. But people saying that they may know they have the gene, they might be caring for family members and then worrying about thinking this is going to be happening to them. Other people might be caring for children as well. It's going to be, or family members could be caring for children. So it's really it has that massive impact. And then also the impact of those physical changes and decline, and what that does to your mental health as well. But then on top of this, there's also the damage to the brain caused by Huntington's and the central nervous system, and so that's a big factor as well, which can, as we mentioned, contribute to behavior changes and personality changes. Depression, anxiety is quite common in people with Huntington's disease. Psychosis is relatively rare, although I have been speaking to people who've recently had family members who've experienced severe paranoia and actually ended up being sectioned in mental health hospitals. But what we found is that when people try and seek help, is that it's often mental health services, particularly if people tell us about their experiences of community mental health teams, is that they lack an awareness of Huntington's, and they will often say, because the person has a physical health problem, or their mental health problem has got physical causes. They say you've got an organic brain condition, then you need to get help from elsewhere, and we can't support you. But often that help isn't there, and people can have their referral bounce around services and not get any help. And it's sometimes difficult to differentiate between issues which all people have with accessing services, mental health services, which are long waits, being declined access. But then on top of that, people also have these issues of having Huntington's and services not having understanding of their condition. And then another issue is that support is only offered when crisis point is reached, and a person can be, mental health is declining and they don't get accepted, and then eventually you might be able to get support, or people end up being sectioned because their mental health has declined to that point. And even if a referral is accepted, there is that lack of condition-specific knowledge, which in a sense you can maybe understand from community mental health teams, but there isn't seem to be that, people wouldn't necessarily have that knowledge. And I used to work on a community mental health team. We didn't see people with, we didn't see anybody with Huntington's in the time that I was working there. But there is no mechanism in place to give people that knowledge and to ensure they have that understanding. And we actually surveyed in 2023 about 100 people in England and Wales who were affected by Huntington's disease, including family members and carers, and also surveyed health professionals. I think it's 99% of health professionals said that they thought the patients they worked with Huntington's disease had mental health problems, and there was a widespread issues around access to services. And as I mentioned, just that and poor care when people can access it. I've just got a couple, 2 case studies here, which have come up in our research that we've done recently. And the first person is Sam. All the names have been changed, but he's a man in his 50s living with Huntington's disease. His daughter was concerned after he became increasingly agitated and paranoid, unwilling to take antidepressants, and so he started to believe his neighbour was listening to his conversations. He would send texts and call family members every day, and was actually becoming quite paranoid towards his neighbour, threatening them and making paranoid claims about them. And he also told his family members that he was really struggling to cope with life. And the referral was made to social services, who then forwarded it to a community mental health team. They said it was an inappropriate referral and sent it to somebody else. And then it eventually ended up with this community mental health team back to them. But they were satisfied by Sam's assurances that he'd take his medication, and they declined to offer any further support. This was despite the fact that his unwillingness to take the medication had contributed to his referral to mental health services. And 2 weeks after his assessment by the community mental health team, Sam actually attempted suicide and was left with head injuries and broken bones, and has spent months in hospital and required multiple surgeries. Understandably, his family have been left completely devastated by what happened to him, and very frustrated at those repeated warnings to a range of different health and social care services didn't result in any effective action being taken. And then a second case study is of Richard, who was also a man in his 50s, and after experiencing deterioration in his mental health, including severe paranoia, he's referred by a neuropsychiatrist to a community mental health team for ongoing support. And I think sometimes the feedback can be, this referral wasn't of a good enough quality or didn't provide enough information, but this referral was coming in from a neuropsychiatrist, and the referral was rejected without an assessment taking place on the basis that the community mental health team wasn't able to provide the care because his mental illness was related to physical health needs. So I think they're just 2 examples that really highlight some of the issues that people with Huntington's are having in accessing mental health services. I'll try and end on a positive note as well. So in terms of what we're doing as an organisation to improve things, we're working on a mental health guideline for health professionals, for mental health professionals. And I imagine community mental health teams will be a big audience for this, we hope, and that we can at least, I think sometimes it's that lack of understanding, or people can be, mental health services can be quite fearful of the care of how to provide the right care to someone with Huntington. So we hope that this will help with that, and work's already started on the draft, and we're hoping to get input from clinical psychologists and neuropsychiatrists, and hopefully professional bodies as well who we're seeking endorsement from. We're going to be publishing in a couple of weeks, the 14th of November, a mental health report, and that's going to be setting out the findings of our research from our 2023 survey, as well as more recent case studies, highlighting the issues that people with Huntington's are having in accessing mental health services. Some of the three things that we're calling for are all people having a named health professional to coordinate care. And this is not something, this is just mental health, but just having a person who can act as a local expert on care needs and have that role of educating other health professionals and making sure they're able to provide the right care for someone with Huntington's is really important. And from our own research, it's what people tell us that they want. One of the things that people most want to change in terms of how their care could be improved. And we're also calling for better access to specialist mental health support. This would be access to neuropsychiatry as well as psychological therapies. There is some research at the moment on particularly around acceptance and commitment therapy for people with Huntington's, but there is still quite a way to go in determining which would be the most effective psychological interventions. But we feel that there is a need for definitely more specialist mental health support. And then thirdly, we're calling for improved support offered by community mental health teams to people living with Huntington's disease. I think at this point it's really around just making sure that people shouldn't find it harder to access services and have barriers put in place to them getting help because they have Huntington's. And I feel like there's a lot more work now to be done on maybe more detailed policy solutions and really thinking around how we can work with decision makers at a national and regional level to push for improvements in care. But the first part, I think, for this report is to show that these issues are happening, because some of the conversations that I've had, how some of the feedback from officials and the NHS has been, how much is this happening and how much of an issue is this? And I think this report will help us to show that this is happening, this is an issue. People are either finding it hard to get help, and if they are getting help, then the care is often poor and something needs to be done about it. And hopefully we've come up with some solutions and we can work and develop these a bit more as well. And that is it from me.
Fabulous. Thank you so much, David, and wonderful to hear about this forthcoming report, which I think, as you say, is going to be very important in kind of taking the conversation forward. Very interesting that for two such different conditions in some ways, we're already kind of converging on some points around education, the referral process and how that might be flawed, and also what is the most helpful form of mental health treatment for these conditions. So really interesting. We turn now to Jackie, who has lived experience of Huntington's disease. So Jackie, over to you.
I'm going to say I'm not an expert, sort of, I don't know, you don't feel like an expert. Some of it goes into what they were talking about, Parkinson's disease and obviously Huntington's disease. So I've had Huntington's disease in my family all my life. I lost my mother to the disease when I was 12 and my brother was 6. Previously, my grandfather had it. And I took over the care of my brother after the death of our nan. So I was 18, he was 12, and I became his parent and guardian. And it goes with what she was saying about Parkinson's stuff is probably happening a long time before we realised it's Huntington's. So was it being brought up by his sister? Was it losing his mum when he was 6? Was it losing his nan when he was 12? Or was the Huntington's sort of doing weird stuff all along? So he had a problematic kind of life, really. He managed to get 2 degrees, so really bright, really funny, really wonderful brother. But there was always a lot of mental health stuff going on in and out of his life, and never really kind of got sorted with various different antidepressants. It was in a lot of, so it depends which research you read. Some people say people with Huntington's deny it, there's nothing happening, I can't see it, because they've seen it with a parent, they've seen it with a grandparent, they might have seen it with a sibling, a cousin, an aunt or an uncle, and it's too horrific to actually contemplate. But also there's a school of thought that whatever is happening in the brain is they're kind of not aware of these symptoms. So there was mental stuff going on a long time before the physical stuff. It used to be back in the day, Huntington's chorea, which is Greek for dance. So anybody with Huntington like this, but then never, if I'd be like that. And it's disturbing to watch as a carer, as a family member. It's disturbed the dog who's just walked in to see what I'm crashing about with, and it's quite disturbing. So they're never quiet. Then I saw this movement, and then you realise that he's inherited the faulty gene as well. And you get, in my situation, passed from the GP to the crisis team, to the neurologist, back to the GP, back to the crisis team. It's a physical disease, so it's not the mental health team. It's a mental disease, so the physical team don't want it. So you end up falling between a rock and a hard place. The suicide risk, somebody asked a question about Huntington's. I don't know the figures, but I think it's about maybe 20% more than in the general population. There is a big suicide risk. Again, whether that's stuff, the mental stuff, health stuff that is happening, or whether it's that kind of knowledge about your future. We've got a crystal ball with Huntington's, which you don't necessarily want, and not a lot of other diseases have, in that it is genetic. So you can go at 18 and have a blood test, a predictive blood test, and you can walk out of that office knowing whether or not you have got that Huntington's gene. And if you've got it, you will suffer the same fate as a parent who has passed that gene down to you. So it's not a crystal ball that you want, and that weighs heavily. And the support, mental health support pre-testing is quite intense, but post-testing, you walk out of that door of the office, and there's not a lot of post-testing mental health support for people. Sometimes it's just, I'll see you in a year, because you can have a test at 18 and might not develop certainly the physical symptoms until your 30s. So, but that's quite a lot of knowledge to have. And I know when you see things about testing for Alzheimer's and other diseases, people say, probably wouldn't take a test. It's not a test. So you've got that crystal ball. So I think it plays with your mental health stuff going on in your brain is deteriorating. So it's an organic brain disease, but there's also that kind of history of grief, of loss, of trauma for generations. Your house is chaotic. I lived in a house with my grandmother, my mother who had Huntington's, my uncle who was Huntington's, and baby brother. So you've got all that chaos going in your life, and that transmits. So my own experience is that the support wasn't there, and it was really bad. And I've just done a bit of a sort of straw poll over a couple of forums, and these are just comments I've pulled off that somebody had put they'd recently tried committing suicide twice, but it had been signed off by the psychiatrist, and the GP had no idea. Another one, loved one suffering with psychosis, going round and round in a circle with consultants and the mental health team, both arguing that it's not a Huntington's matter, but the Huntington's person who might not be nearby in your town and things. And that's another problem, kind of getting somebody to go. Our nearest was Leeds, but in later stages, when you come into more of a crisis, really, it's a long way to go, and very, very difficult. Another one had a loved one, mental health, on a section 2. They're actually flourishing in there because they'd been hoarding, they'd not been looking after themselves, they'd been neglecting their home, very common, neglecting themselves, very common. But they were then going to be appealed and discharged, and the family knew that it would just be back to square one with the family picking up the pieces. They'd actually put on, which is a pertinent comment, take of it what's the point in giving somebody with a brain damaged person human rights kind of to appeal and go back home, to go back in the situation. So that's how they felt. So I think the named person would be helpful because like I say, you're going to the GP, you're going to the neurologist, you're going to the psychologist, you're going to the psychiatrist, and all of these people, and you get passed around to the point of a carer and a person with it, you don't know what's happening. And I think also there's often with Huntington's, I don't know whether it's similar in other diseases, this kind of I'm absolutely fine, I'm absolutely fine, nothing to see. So they don't necessarily want to engage in services. Also, sometimes people are having a neurology appointment and they're saying there's no, you've not got symptoms yet, but they've not worked for 10 years. So something's going on in that they've left a really, really good job and not working. But, well, it's not I can't see anything yet, nothing to see. It's just depression, anxiety. So there's a lot more work to do. Is it just general depression, or is it caused by the anxiety? I think the testing, let's say an overcase, and that was it. It's absolutely destroyed. This positive test has destroyed their life. Other people have to know, and they can make choices and reproductive choices, which is an important thing. But again, for the carers, I think you're involved, and they would probably say that you're involved in a whole family situation, maybe not more so than some of the disease with the genetic things, and you've got other siblings. Like I say, in my house when I was growing up, my nana lost her husband and both her children, and had 2 grandchildren at risk. So that's a massively complicated thing, and I don't think that there was anyone much batting in her corner, and it seems to be a disease, unfortunately, that's splits families apart rather than bringing together. I think because there are so many different people with it, so there's often not a lot of family support available, because people might, like, if it's 3 out of 3, you might be a child, and your mum, your aunt, and your uncle might all be in a nursing home, and that's difficult to deal with as well. And looking at things that might be me in this nursing home, what choices do you have? So I think it could be a lot better. They've got good resources, the Huntington's Disease Association. I think written resources. I don't think they use resources like myself as they could be. I do a talk to Leeds University to mental health students, and quite happy to talk to anybody. So I think there are resources that might resonate differently to a bit of paper. I don't know, but it's complicated, and with a lot of these things, it's also funding, isn't it? A lot of it comes down to money. So there's a lot more people with Parkinson's. That was evident with the number of Parkinson's disease nurses. There's not that resources for Huntington's, and you've had in the past, not so much now, but you kind of read debates about it, and some people say, well, don't have children, then that's the end of it, which it can potentially be. And there are ways of having children without Huntington, without the gene now, kind of ways, but people will always have children or not know about it, or various things. So it's not as clear cut as that, but hopefully, like I say, I'm 3 generations, and there wasn't much different really for my brother than my mother and my grandfather. That my mum spent the last probably 5 or 6 months, I imagine, because my nana was old, and she spent it in the local local lunatic asylum, now part of Huddersfield University, funnily enough, Stores Hall. But then, as a child, I'm visiting your mother in that, and the stigma of that as a child in school, that you've not got a mother at home, is very telling. So probably it's impacting on your mental health from a very young age.
Absolutely, yeah. And actually, for a different project as part of DeNPRU Exeter, we met a youth advisor from the Huntington's Disease Association yesterday, and he was talking about, yes, the work they do to sort of, work with teachers and explain why somebody might be late or why homework might be difficult to complete, because there are so many sort of attendant life environment issues that need to be understood and talked about as well. But I mean, thank you for sharing, Jackie, because I think it's so powerful, as you say, to hear that story of kind of how it affects not just an individual but a family. And it's absolutely wonderful to hear that you speak to the mental health nurses in Leeds, because, you know, every little bit that we can do on this education journey is so valuable and so powerful. And so I think that is I'm going to derive some hope from that. Yes, thank you so much. We're going to move to Rick, who lives with motor neuron disease, to tell us about his experiences of accessing mental health services. So Rick, over to you.
Thank you very much. I hope you can all hear okay. My life has been reasonably complicated in the sense that I was abused as a child, and this gave me complex PTSD, and that's had some effect on my mental health throughout my life. I also live on the autistic spectrum, and that's also had a considerable effect on my life. That I think has been largely positive, because, for example, I became obsessively interested in chemistry and biology, and eventually became a biology teacher in a sixth form college, head of science, and then became interested in assessment and ran international A-level biology for one of the international exam boards. During my working life, my mental health was variable, I think it's fair to say. I had periods of anxiety and depression. And I also, having eventually in my 50s been diagnosed with PTSD, I started getting talking therapy in the NHS, and then it became very clear that that wasn't going to be, that wasn't going to give enough sessions to solve the problem. So I ended up spending about 5 years of talking therapy, which was actually done by the same person all the way through. I no longer have PTSD, so I no longer have nightmares, I no longer have flashbacks. The dissociative symptoms that I used to have almost all disappeared. The one thing that hasn't really resolved itself is anxiety. More or less at the time that I finished the therapy and was just thinking, oh, that's good, I was training teachers on an island in the Indian Ocean, and I'd just been taking photographs of the sunset. And I lay on the bed and looked down at my leg, and I could see the sun shining across it at an angle, and I could see the muscles doing absurd things under the skin. I'm a biologist. I knew that wasn't good news. So there was then a very long period where I had great difficulty getting diagnosed. And I had great difficulty getting diagnosed because once my daughter had persuaded me to go and tell my GP all my symptoms in one go, instead of going with one symptom at a time, my GP said, I think I know what this is. Do you want me to tell you? So I said, well, you're going to have to now. So she said, I think it's motor neuron disease. So good spot by the GP. She put me in for an emergency appointment at the neurology clinic, and they rang her up and said, don't be stupid. Of course, it's not motor neuron disease. Take him off the emergency list at once. And I then had 5 years of seeing neurologists, them seeing neurological symptoms like Babinski's syndrome, which is Babinski's reflex, which is where your toes turn up like a little baby. Whereas if you tickle the underneath of your foot, your toes will turn down. They saw those symptoms, but they'd read my notes. My notes said, this man has been diagnosed with PTSD. He's been seen repeatedly by different neurologists, and they all believe his symptoms are related to the PTSD. Eventually, my GP became rather fed up and I became incontinent and sent me to A&E. In A&E, I was seen by a wonderful young doctor who had not seen my notes and looked at the patient in front of her and sent me to see the head of neurology, who spent an hour with me and said, yes, Rick, you have a serious neurological condition. We don't know what it is. It's going to take some time to find out. And so I came at mental health in relation to MND in an odd way. It ended up with me being diagnosed with primary lateral sclerosis, which is actually a rare variant of motor neurone disease. Most people have ALS, which affects both upper and lower motor neurons. I have PLS, which affects only the upper motor neurons. However, in other respects, the conditions are all very similar. They're heterogeneous. Everybody I meet with MND, and I've met a lot of people with MND over the last few years, has a different expression of the condition. About 50% of people with MND have some behavioral changes. And for example, I cry very easily, so I have emotional lability. And also my planning capabilities are now those of the average house brick. Whereas I was an extremely effective project manager. So it's had some effect on my planning capabilities. And there is still the underlying anxiety from having had PTSD. So there have been a couple of, oh yes, I know what I wanted to say. Yes, so roughly about half of people who have motor neuron disease have some kind of cognitive changes, and about 10 or 15% that progresses into a particular form of dementia called frontotemporal dementia. So some people with ALS will develop dementia, and of course it's also true that having motor neuron disease doesn't make you immune to any other neurological condition, and some people who have motor neuron disease also have Alzheimer's. So once I had been diagnosed, I'm in the fortunate position that in the area that I live in, there is a multidisciplinary clinic which looks after people with MND. And that means when I go to an MND clinic, there is on-site a speech and language therapist and a physio and a psychiatrist and various other people. And so if the consultant says, I think it would be a good idea if you saw a physiotherapist, I can go into the room next door and see the physiotherapist there and then. That it contrasts with the situation where it's still true that in some parts of the UK there are not multidisciplinary clinics. You go to your neurologist, and the neurologist says you need to see a physiotherapist, and you have to make an appointment to see the physiotherapist. That's absurd, because we know that multidisciplinary clinics increase life expectancy for people with MND more than any drug that is currently known for the treatment of MND. So the average life expectancy, the median life expectancy, if you see a multidisciplinary clinic, is about 18 months, and it's 11 months if you see a separate neurologist who makes other appointments. So I struggled with anxiety about some specific issues during the time that I had MND, since I was diagnosed with MND. I had made contact, having been advised to do so by a friend who had MS. I had gone to see my GP, and we'd talked about hospices. And she said, I'm going to have to use the word palliative care. Don't be frightened by that. But your friend is absolutely right. Making contact with a hospice would be a great idea, because our local hospice offers, for example, living well therapy. And my particular motor neurone disease is slowly progressive. I've had symptoms for about 20 years. For the last few years, I've been going to living well therapy. The result of that is that when I've needed psychological input, it's actually come through the hospice. So the hospice has been absolutely brilliant as a means of accessing all kinds of things. And in fact, they've been very helpful in moving on many things. But to give you two specific examples, I'm not frightened of dying, but I knew nothing about dying slowly. I knew quite a lot about dying quickly because my dad was a specialist in, he was a doctor who specialized in treating people at accident sites. And so I knew quite a bit about dying quickly, but nothing at all about dying slowly. And I was absolutely terrified. And the hospice arranged for me to see a psychiatrist who helped me through talking therapy. I also came across a book With the End in Mind by Sue. Please, can you remind me who With the End in Mind is by?
It's by Catherine Mannix.
Thank you.
And she's brilliant. Yeah.
She's a palliative care consultant with vast experience. It's not full of case studies. It's a great book. The result of the psychological intervention plus that book is that I'm no longer terrified of the process of dying. I know that it won't be a terrifying process. I know that I will die here in this room, and that I will be surrounded by my family. And it will be much as my mother's death last year from Alzheimer's was. I held her hand and she quietly slipped away. It was very beautiful. I know my death will be similar. Yes, the other thing is because I was abused as a child, I think, I've always been terrified at having strangers in the house. And so the idea of having carers completely undid me. And again, I talked to people at the hospice about that. And they arranged for me to see a psychiatrist, a different one. We talked about about it and established that all of the things that I was frightened about were perfectly normal, and that it was okay, and it is okay. In the last few months, we now have somebody who comes in every day, different people every day, and the agency has agreed only to send women, because I'm terrified of some men, and they've all of this has become possible because of the support provided by the hospice. So the hospice movement for me has been really important. I know there are a lot of people who struggle with the same issues, who find it very difficult to get support, and I would encourage those who have contacts with other hospices which don't offer the kind of services that Arthur Rank Hospice in Cambridge offers, to look at whether it's possible to diversify what they do, to include those kinds of services. Okay, thank you very much.
That was perfect. Thank you, Rick. And yes, hospices are sadly overlooked, I think, when it comes to possible services that people could reach out to. And I think what both of your stories have kind of illustrated is how that access to mental health services, or lack of access, you are either unlocking somebody's life and improving things and making things possible, or you're shutting it down and making what is already a challenging situation much, much worse. And I think the other thing that struck me from all the speakers is the fact that we arrive at a diagnosis of one of these conditions not as a blank slate, but with all of our life experiences, and those have informed our mental health and our kind of ability to cope or deal with whatever challenges are thrown up next. So yeah, I think that's really important for us to keep in mind, that it's not sort of, you know, the diagnosis happens and then we respond with our mental health and what needs to happen for that. No, it's built up, it's cumulative over a lifetime.